Welcome back, listeners. Before we get started with our interview, I want to tell you that we have a sponsor for today's podcast, International Medical Industries, IMI. They are an American medical device manufacturer specializing in devices that enhance the safety of medication from the pharmacy to the patient. I'd like to welcome my guest today, Dr. Keith Berge. He is an anesthesiologist who has officially retired after, I believe it was 35 years, you said?
Yeah.
More or less?
More or less, 33.
33, okay. We won't make you older. We won't make you any older. He has a perspective that I haven't covered yet in any of my podcasts. And so I'm really looking forward to having this conversation with him so that he can share his experiences. So welcome, Keith. And
Thank you,
the question that will start us off is, in the 33 years that you have in the OR, have you had any experiences with coworkers who have been working impaired and were later found to be diverting?
Yes, multiple times, actually. So, and it's one of the challenges of the drug that our people gravitate towards, which is fentanyl, which is unlike alcohol or benzos or other things where you're stereotypically maybe stumbling, slurring your speech, things that we all associate with intoxication. You don't see that with the opioids. You can have a very high level of function and yet be impaired with the drug.
Yeah, that was going to be my next question is, I know when you and I had talked previously, it's not always that easy to spot, which is perplexing to people, I think, when they find out that their coworkers have been diverting, and especially if it's, as you said, fentanyl, typically that it isn't that easy to spot because they're not slurring and stumbling. So, I mean, what does it look like? Is it possible that you're working alongside somebody and can be doing this for quite some time and just not be aware? What finally tips you off that there might be something going on then, if it's not that obvious?
Sure, absolutely, yes. It's if somebody is diverting fentanyl and from the workplace, odds are they are using in the workplace because once you get to that point, you're basically trying to stave off withdrawal symptoms continuously, basically. So at the one extreme would be you can't detect anything at all unusual in their behavior, all the way to the other extreme where they have a respiratory arrest and drop to the floor and turn blue and aren't breathing. So with those as being kind of the two extremes, likely they're going to be somewhere in the middle. And while you see these lists in textbooks and whatnot suggesting, well, you look for the addition of long sleeves, you look for crabbiness, you look for frequent bathroom breaks and unexplained absences. All of those things are easily explained away by, potentially a dozen other things it might be. If somebody, an in-room provider is agitated, sweating dilated pupils, desperately needing to go to the bathroom, maybe they have diarrhea, or maybe they're in withdrawal, and then they come back and they have pinpoint pupils and they're calm and relaxed and in a blissful state. Well, sure, you'd look at that and say, I'm a little worried about that behavior, but it's almost never that obvious. So again, I'm kind of painting caricatures more than things that would likely tip you off. What would likely tip you off? Changes in behavior, somebody who was previously very reliable not being reliable, somebody whose opioid use for cases is accelerating. So whereas they might have used well within the range of their peers for say a laparoscopic cholecystectomy, and maybe they were using on average 250 micrograms of fentanyl for a case, and now they're using 10 times, they're signing out 10 times that much. Yeah, that's certainly a tip-off, because people do habituate to the use of these drugs, to the euphoric effect that they're after, and also to the just the dose that they need to stave off withdrawal, and their needs accelerate. The most dramatic I ever saw was somebody who first used on a Monday, and by Thursday we caught them because they couldn't hide how much they needed anymore. That's very much an extreme. It's usually not that fast, but it can take off that fast. But it inevitably takes off. It accelerates, their needs accelerate, and so usually that's how somebody gets found. That, or they're found unconscious or dead in the call room. So.
Right. And then it becomes very clear. Okay. So the first couple of things that you mentioned in terms of the changes of behavior, then that's something that those working in the OR, we depend on them to notice and to speak up and say something. The other issue of using more, dispensing more, charting more, right? Using more on their patients, that isn't necessarily, I'm guessing, things that you would notice in the OR because they're doing their thing, you know, at the head of the bed. But that would require probably somebody from pharmacy or quality or whoever it is that's in charge of your program is the one that would notice that. And then you couple those two together if nobody has said anything about a singular issue. Would that be a fair assessment?
Yeah, absolutely. So for many years, when I was trying to improve our controls in the OR, I was relying on, word of mouth, basically. Somebody wasn't acting right. So I would actually enlist the aid of everybody in the OR. So it's not just anesthesia providers. We're the ones that have known about this problem for well over 100 years in our ranks, actually. But the circulators, the scrub nurses, anybody else who might see something unusual to let me know, because it's a risk to our providers who are at risk of overdose and death. It's also more recently become painfully obvious it's a hazard, a risk to our patients, and not just having an impaired provider perhaps taking care of them, but perhaps a provider who's tampering with the drug. Typically our people divert by dilution, or somebody else in the OR who's not an anesthesia provider, who's just simply stealing the drugs off the anesthesia tray and substituting it for God knows what, another clear colorless liquid that could just as well be, tap water, toilet water, for all anybody knows. It's being injected into the patient. So.
Right. Yeah. So good point. It's definitely a team effort. I mean, you have to get everybody involved, and talking about the long sleeves and all of those other things. I think maybe some of those things are there, but like you said, it's easily explainable. And so you wouldn't just take one singular thing, but it's that change over time that would be your real trigger. And of course, by that time, things have escalated. And then if you're looking at, quantity used, then that would, on the flip side, I know for me, when I've done monitoring at facilities, I mean, the relationship with the chief anesthesiologist is crucial, because I mean, that's who has insight into the OR. I don't know what's going on into the OR, and what has changed. And so if I have a chief that didn't take it seriously, then I didn't have a whole lot of confidence when I took some data to him to say, hey, can you look at this in relation to everything else that's going on, versus one who did take it seriously and I knew I could count on them to, be open, honest assessment. Because for the most part, I mean, I guess except for maybe a long case, there's just one anesthesia provider in the room, right? So you really do depend on all of your nurses and everybody else in the room.
Yeah, that's the problem with anesthesia as a source for diversion, is that typically our providers work alone, basically in privacy. They're behind a drape. Nobody
Yep.
has eyes on them. They can do things with open ampules of drugs that nobody else in the facility can do. You're not seeing that in pharmacy where, or in the ICU or in the nursing station where people tend to have eyes on each other. In
Yeah.
the anesthesia world, anesthesia providers are expensive, and there's not going to be redundancy. They're not going to be more eyes on each other. And therein lies the weakness. I kind of failed to answer half your question a moment ago about other ways to look at it, and the answer is absolutely yes. One of the ways to look at it is sort of systemically to have somebody keeping an eye out surveillance wise, looking at is there anybody whose needs are accelerating? Is there somebody who's using unusual amounts? Is there somebody whose patterns are changing? And as you say, if you don't have buy-in from the anesthesia department, if you get the response, we don't have that problem here. Everybody has that problem there. Anywhere there are opioids, there are people who are seeking to get their hands on them and divert them. And so, yeah, you need multiple approaches to it, and one of them is robust active surveillance. In the years that I spent where we were sort of reactive to the problem and looking for it when somebody brought me a problem, we were behind every time, and we shifted over in the past 10, 12 years when I was working at Mayo to a more active hunting mode. And when you hunt, you find it. So you need to be doing both. You need to be
Right.
prepared to look for it if there's a concern, but you also need to be actively looking for evidence of diversion.
Right. So tell us about that more active hunting mode. What was it that you did?
Well, we created a team that did that in the OR suite. So I kind of, just to make it easy, break my career down into decades, thirds. So the first 10 years was me trying to figure out how we could improve our controls in the OR to protect the anesthesia providers from fentanyl addiction, which was, truly proven to be ravaging our ranks and was killing a lot of anesthesia providers every year. At that point, I don't think anybody really recognized the hazards that it presented to patient safety, but be that as it may, I did not succeed. I thought maybe education was the best way to go. Relatively early in my career, the American Association of Nurse Anesthetists and the American Society of Anesthesiologists combined their efforts and made a video called Wearing Masks, which was really an outstanding educational effort to try to bring up to our people the hazards that were presented to them and to educate one another that we had to be looking out for one another. We used that aggressively for, well, still 30 years later, but I pinned all my hopes on that educational effort, and that's not good enough. Telling people don't do drugs, it doesn't work in South Park, and it doesn't work in the real world either. Some percentage of people are going to do it. So about 10 years into my career, we were casting around looking for ways to improve our opioid controls in the OR. Controlled substances, absolutely. But really, if you look at what gets diverted, it's opioids. And if you look at what opioid gets diverted, it's fentanyl. So my shorthand is fentanyl. But and we looked at all the different systems in place. None of them were particularly good. But at that point, the ADMs were just coming on the market. Pyxis sort of Mark I was available. We decided to go with that, recognizing that doesn't really do anything to stop the way our people divert, which is by dilution. We put in a system where we got the waste back at the end of the case. So if the practitioner signed out 5 cc's of fentanyl an ampule, use 3 cc's during the case. We would get the 2 cc's in a syringe rubber stopper into a Ziploc bag with the Pyxis receipt. And I use Pyxis again because that's what I'm used to. There are others, Omnicell, etc. I'm not playing favorites. That's just my shorthand. Ziploc dropped into a secure return bin, collected at the every day by pharmacy, securely transported down to pharmacy, controlled substances safe under cameras, taken out, reconciled with the anesthesia record, stored in the C2 vault until such time as it could be transported to the incinerator and destroyed. But that gave us access to have everybody's waste on hand if we wanted to assay it for to make sure it hadn't been tampered with. Since our people do tend to divert by dilution, they don't take it all. It's not all for me, none for you. It's half for me, half for you. And very hard to detect that with any currently available at the time technology. Spectrophotometric testing only said present absent, not dilution at the time. And we put that in place in an effort to try to more quickly confirm if there was diversion happening, if we thought it might be happening. And to our lasting astonishment, it really dramatically decreased our incidence of diversion in that setting. So we went from basically sending one anesthesia provider a year to treatment for fentanyl addiction to, in the subsequent 20 years, 2 total. So that's anecdotal, but it was such a dramatic difference that we were pretty impressed that just that very, very seemingly minimal bar created a barrier in people's mind that said, if I do this, I'll get caught. So I choose not to do this. And that kind of was so we stumbled into what I think was a pretty good solution. It's not cheap. It's not easy to do. It's logistically tough. It's hard to get all that back, but it's the only real way that you have. So if somebody were to come to me and say, I'm worried about so-and-so, I think they might be diverting. We'd have their waste already, and we could continue to collect all their waste. We could send all their waste and see within a day down to toxicology lab for the gas chromatography mass spec or the expensive test, the gold standard test, to see are they tampering, and if not, it's great to know they're not. And it's tough if you don't have a system like that. It's very hard to get your hands on people's waste because they protect it, because they know that's the way they could get caught.
Right. What about, what I have heard is that anesthesia providers just use it all. I mean, they just chart it and they use it. They don't want to return the waste. It certainly takes more effort to return waste. And then if they know that you're monitoring their waste, then I'm not going to return it. So that wouldn't take care of that situation. I mean, did you just see people start to pivot in that direction? Well, I'm just going to administer it all. Yeah,
I'm certain that there's some of that goes on. So you can look for that retrospectively, say, well, are there providers that never return any waste? That right there would be a red flag. So sure, that's a fair question, and there are some ways you could work around that. That's sort of sloppy practice, because that's sort of letting the size of the ampule dictate what the dose is for the patient, and that's really not how it's supposed to be done. Is somebody that's trying to hide their diversion, is that a technique? Yep, that's a technique, and we know that too. So, and an empty syringe is never truly empty. There's always a bit in there. So that's another way to approach that.
Okay, so someone who never returns their waste would be a red flag. Could that also be, though, a practice issue? And how would you go about, if I came to you and said, okay, I've done this audit, here's this provider, she doesn't have any waste, over the last 3 months, then how would you as the chief go about discerning practice versus potential diversion? Would you just query those around them to find out if there'd been any behavioral changes?
That would be a start. Yeah. You'd look for other, context. And, you know, you, the worst case you would end up with is what was always before just standard operating procedure, which is you'd have to try to get in there and snag one of their syringes to test it, surreptitiously get a syringe and see if it's diluted. That's hard to do, and it's hard to do without arousing suspicion, and it's it's not ideal, but as a worst case, you're right back to where you were anyway. So
yeah, well, and
it
I
presents
guess
challenges.
yeah, and I guess once you've had the conversation with them and you've like, shame on you, this is bad practice, then they would have to start changing their practice. And if you're taking back your waste, they're going to have to return waste. So it's like, now what am I looking for? Because they know you're going to test their waste.
Yeah. Could they beat that? Oh, yeah. Any system you come up with, these are smart, clever, desperate people. Yeah. Any system is beatable. You will never have a perfect mousetrap, and we know that. So you kind of do the best you can, which is what sort of surprised us when we ended up with this system that worked, and it worked in a way that we didn't expect it to. So is it defeatable? Yeah, absolutely, it's defeatable.
Okay. So fentanyl's the number one. Are there any other non-controls that we should be looking at that maybe would help them through the OR with the withdrawals to just kind of hang on if they're trying to avoid using it while they're at work?
I'd say probably not. I mean, there are other things people divert that look innocent and yet suggest diversion. Ondansetron, Zofran, anti-nausea drugs are popular because people do suffer nausea from the drug that they're abusing. So there's that. The beta blockers, somebody might mix beta blockers in with the drug that in their syringe that is being administered to the patient to try to disguise the fact that they didn't get opioid in the injection that they were being given, so that the bradycardia that might accompany analgesia for the patient is not in fact analgesia, it's just beta blockade. There are things people do to try to obscure the fact that they're diverting. And then, are other things diverted? Yeah, anything can be diverted. Propofol is a drug of abuse. It looks like milk on your cereal, so that it's not clear and colorless like fentanyl is, but so that helps a bit. Ketamine, benzodiazepines, they're all potential drugs of diversion, but interestingly, I was working with Minnesota Department of Health and Minnesota Hospital Association joint effort that involve a lot of others trying to address diversion from healthcare facilities. And so if a healthcare facility suffers a diversion of theft, they have to report it to the DEA. And that's on a Form 106, it's called. And so the DEA teamed up with the Minnesota Department of Health and just analyzed about 6 years worth of data on Form 106s and looked at what was being stolen. And by far and away, it was opioids. So about the first 8 on the list were opioids, and then a benzo, and then several more opioids. So it's basically opioids. Yeah.
If you only have a certain amount of time, put your effort where you're going to get your biggest bang for your buck. Okay.
Yep.
I know that I've heard you speak in various venues, and you're pretty vocal about your belief regarding not placing an anesthesia provider back into an anesthesia provider with a substance use disorder, even in recovery. back into the OR. You have, pretty strong convictions that it just won't work. They will relapse and it's not a great idea. So tell us a little bit about why you feel that way, what your experiences are. Let's talk about that.
Sure. Yeah, and just to clarify it a little bit more, it's if an anesthesia provider is addicted to drugs they obtained from the workplace.
Okay.
So we're not talking about alcohol or
Okay.
other drugs. If they have diverted drugs from the workplace,
Okay.
that's kind of a bridge too far, in that they stole it from their patient, basically. But early in my career, so I joined the staff of the Mayo Clinic in 1988. In 1990, Emil Mink and JAMA published his controversial, but at the time, state-of-the-art paper on the relapse rate in anesthesia residents that had become addicted to workplace drugs. And in his analysis, which was retrospective data survey of program anesthesia to residency program chairs, that he found that about 2/3 will relapse. And that is to parenteral, if they are abusing parenteral opioids. And of those 2/3 that relapse, about, I think it was 16% will, their initial manifestation of having relapse is they're found dead. And these are young, healthy people. These are typically people in their mid to late 20s who have a lot to offer their families, the world, and for the sake of allowing them to continue a career in anesthesia when they are still MDs, they can train in something else. They're not even fully hatched yet as anesthesiologists. They're being subjected to a hazard of death that I just find unacceptable. I don't think OSHA would allow us to put somebody into a situation where they have a very significant risk of being found dead in a call room, just because they like what they're doing and they want to keep doing it. I think they should be steered down another path. And I always tried to steer our residents who had become addicted to workplace drugs down another path. And the answer was always, well, if there's one person that can beat this, it's me. And great. But so, yeah, I took a lot of heat for that over my 30-year career because people don't want to hear that. And they think, well, you're a jerk, you're a hard ass, you're nasty. Everybody deserves a second chance. Well, yeah, I'm not a bad guy. I'd like to see them survive. I don't think it's a good choice to subject somebody to that risk of death when they can go on and have a long and happy career as something else. Can I prove that they would not become a radiologist and relapse to fentanyl? No, I can't. But availability is certainly a factor. So.
Okay. So would it be fair then to say that it is not that you don't believe that it is possible that they could go back into the OR and not relapse, but the statistics are so high that you just don't believe it is worth the risk and you'd rather have them use their skill sets in another arena and not take that risk because the consequence of failure could be death and it's just not worth it.
Yeah, absolutely. I know it's possible. I have friends who have succeeded in returning to the practice of anesthesia safely to this point. They haven't relapsed yet. I think there's always at a higher risk of relapse and consequently death. But so, yeah, certainly it's possible. And I would often be in a room full of people that had done it and they'd say, well, I did it. And I'd say, yeah, but the people who didn't succeed, relapsed and died are not here to give me to share their voice with us either.
Yeah.
So,
Okay.
do they exist? Yeah, we know they exist, or existed in past tense, because they're dead now, because they tried and failed. So,
Right. Okay. That makes sense. All right. So, in addition to looking at waste or having at least having waste available to look at and getting everybody in the OR to understand what diversion is and to speak up if they see something that's concerning, do you have any other recommendations or words of wisdom for those out there that are trying to do a better job it's hard looking in the OR. It is really, really hard. Not only because those of us monitoring don't have a foothold into the OR, but anesthesia, they got their little wall of peer review, and they're untouchable in a lot of places because you know, the hospital administration just kind of does what anesthesia tells them to do too many times. So it's a
yeah.
really hard place. So do you have any other words of wisdom that may be helpful?
So that brings me to the third of my career, which was when we had Mayo had a kind of a high profile front of the newspaper diversion in one of our outlying hospitals. And it was outside of the operating room, and it became clear that we had a problem that needed addressing, which was diversion from outside of the operating room as well. Mayo asked me to be on a task force to address that, and to my horror, I found that I knew more about it than anybody else did because of my experiences inside the OR, and I didn't feel like I knew nearly enough. But we did create a drug diversion prevention committee and a response team, and we tried to create a way to take what we had in the OR out of the OR and use it. And that turned out to be successful. We got more aggressive about hunting outside of the OR as we were hunting inside of the OR. And when you look, you find it and whatnot. But that's not really the question you asked. Yeah, it's tough because so the third of my career, I worked with people that do what you're doing right now. And that was my job. And I got to see the challenges through their eyes. And yeah, it's tough to break into the OR, especially if the anesthesia department management doesn't understand that they have a problem in the first place. And
Yeah.
you get that. You get people that say, well, we don't have that problem here, which is absolutely absurd because, yeah, we do. We always have, and we always will. We have gallons of rocket fuel passing through our hands every day. So it's no surprise that that's where people who are determined to get their hands on rocket fuel go to get rocket fuel. They go to the OR. So how best to work if you are coming at it from outside of the OR, you really need an ally in the anesthesia department. And in a perfect world, it would be the chair. But in my world, it was me because I did the reverse of what you're doing, which was I broke out of the OR into the broader sphere, and you're trying to break out of the broader sphere and into the OR to make an impact. And what you need is you need anesthesia providers that understand it's a problem. Many do. Many anesthesia providers do because we've been trained since we were relatively children in anesthesia that this is a problem within the ranks of anesthesia. And it's an insular area. People don't like being told what to do. For some reason, I've always sensed some acrimony between anesthesia and pharmacy. I think it goes back into mists of time, maybe when anesthesia departments used to charge for the drugs that they provided and sort of jealously guarded that revenue stream, and pharmacy was saying, yeah, but we're the drug people, we should be controlling the flow of drugs through our facility, which I'd say, yeah, that's obvious. But so I think there's some of that that goes on. I've never really quite understood why there's sort of a contentious relationship between
Yeah.
pharmacy and anesthesia. But you need to break that down. You need to have a cooperative effort. Everybody needs to understand, first and foremost, this is a patient safety issue. We are all trying to protect our patients from tainted drugs, tampered drugs, wrong, anything, whatever. And then we're trying to provide safety for our providers, our personnel, trying to, so it shouldn't be an us against them environment. It's a very, very challenging environment because the anesthesia provider, I'd say, is always going to be alone behind the drapes with an open ampule. And so one other thing that has come along in the last couple of years, which I applaud, and I have to say, 10 years ago, I would have said, this is a scam. This is pharmaceutical companies trying to maximize their profits by selling you a cc of fentanyl, selling you a 50 microgram increment aliquot of fentanyl rather than a 5 cc aliquot of fentanyl. Well, in retrospect, I'd have been wrong. That's a good idea because, if you can sign out of your ADM the smallest amount that you can, that you're likely to use, and if that's 50 micrograms or 100 micrograms or 250 micrograms, take out the least you're likely to use because it's the waste stream that's really, really vulnerable to attack. And if there is no waste stream, then there's nothing to attack. So I know Fresenius Kabi, who I don't work for, they don't pay me. I have spoken on their behalf before because, I became convinced that their efforts to minimize the amount that gets signed out was, in retrospect, a really good idea. So, are there things that can be done? Yeah. Are they going to work? Not all of them, not all the time.
Yeah. No, you're right. That bringing it down to the smallest dose. Waste. I mean, that's a lot of what we've talked about today is the whole waste. It's a very, very, very easy way to divert. I mean, it's going in the trash. It's not hurting the patient. It's going in the trash. It's not affecting the revenue cycle. I mean, it's literally going in the appropriate receptacle, not the trash, but,
Right.
And so to make it the smallest. And so that is a good way. And I think you're spot on the relationship between pharmacy and anesthesia or whoever it is that's monitoring. You might be right on the charging. I kind of feel like it's a bit of, pharmacy is so heavily regulated by so many different agencies, and directors of pharmacy tend to be very guarded because their license is on the line for so many different things that they theoretically have direct control over, but really don't, because there's so much going on. And so I think that that's maybe part of the clash, is that pharmacy comes in hot and heavy with regulatory, and this is drugs, and no, you can't do that. And anesthesia, just by nature of who they are, they don't want to be told what to do. And the, pharmacy doesn't want to be told what to do when it comes to meds. And so I think there's a little bit of a clash there. I worked at an institution where when I was put in charge of the controlled substances, I began to develop that relationship with anesthesia, which had been horrible up until that point. And we were able to turn that around. I take more of a, there's regulations, but there's also real life. We need to work together to find that balance. But, the anesthesia chief said they can tell us anything they want, but it doesn't mean we're going to do it. They can't make us. And that was kind of the attitude, right? And so I think that is the key right there, is that relationship between whoever is doing that monitoring and anesthesia, because you're right, this is about the patient and this is about the anesthesia providers themselves and anyone else in that room, frankly, that, is not being monitored. And so we all need to work together and have those eyes and ears. Oh, I think we have lost some connection here. Hopefully Keith will come back, but we'll wrap that up. And hopefully you all learned something. Oh, there you are.
Sorry, Terry, I lost you there for a moment. Yeah, absolutely. And I think, I have friends in the DEA and the FDA who are law enforcement people. Who do they sit down at the table across from? The pharmacy director and the pharmacy people. They're humorless about some of this stuff, and they ought to be. This is not.
Yep.
So for a anesthesia chair to say, screw you, this is our turf. No, it's not. It's not.
Right.
And maybe they should be in the room with the pharmacy director and those guys with the big letters on the back of their jacket, because that focuses the mind wonderfully about really who gives permission to have those drugs inside your walls in the first place, because they can take it away. Yeah,
that's not a bad idea. We'll recommend that. Invite anesthesia to the table when those people come in and let them see it. But
it's no joke. It's no joke.
Yeah. No, it isn't. All right. Well, thank you very much for your time, Keith. I think this was some great information. I do want to say one more thing to the listeners out there. When you and I talked, you gave me another idea, and that is to look at the amount of dispenses over, I think you said just a 2-week time period, because it happens pretty fast when you are abusing the fentanyl. And so for those of you out there, even though you may not have specific access to types of procedures or, specific things within the OR, just look at the provider over 2-week, 4-week time span and see if their usage went up significantly. And then, of course, I guess you should double check and make sure they're not taking care of, gone from eye cases to heart cases or something, which would explain that. But that is another place to look at just the data in general and see if you see a big change there.
Right. And you need an ally inside the anesthesia department that can provide context for exactly those kinds of things, because they might look at it and say, sure, that's to be expected. Or they might say, no. We got a rat here.
Nothing else has changed. Yep, that's right. Okay. All right. We'll wrap that up then. Thank you very much, Keith. And you have a great rest of your day. It was great talking to you.
Thank you, Terry. Thanks for the opportunity.
Absolutely. Thank you for listening today. If you haven't already, please hit that subscribe button. And you can learn more about our sponsor, IMI, at imiweb.com, where you can see their complete line of innovative, tamper-evident products, including their industry-leading Prep Lock line of tamper-evident caps, which are an active deterrent to diversion.